Thank you so much for the opportunity to be here. Mark and I both just really believe that knowledge is power, and you know, if you can just gain just a nugget here today that you can take away and use in the future, or that you can share with somebody else that's going through an experience. As Maureen kind of alluded to, we've been through many experiences ourselves. We have moved both of our sets of parents from out of state. The first time we did it the hard way, not knowing much, just kind of being that consumer. We were both in healthcare, so we thought that we could probably figure it out. And we did, but we probably could have made some better decisions if we knew what we know now. And I'll kind of share a little bit of our story as we go along. And I'm just going to first of all talk about the aging in place. That's kind of the topic for today, because most people we know want to age in place. And that's a great plan, but we always say have a plan B. So Mark will also talk about the options in transitioning if you decide that staying at home is no longer safe or just isn't practically working. So first of all, let's just talk about some options for in-home care. And my caregiver journey kind of started really young, as both of my grandparents, my mother's mother and my father's father, lived with us at different periods of time while I was a child. So caregiving kind of came naturally to me. But not everybody is a caregiver, and that's important to recognize too. So we're going to talk about, first of all, non-medical care. So this is probably the first thing you think of. If somebody is staying at home and is starting to, I would say, not thrive doing the things that they've been doing for themselves, because usually older folks don't recognize that they're having challenges. It usually takes a relative or a neighbor or somebody that spends a lot of time with them to go, wow, they're really not thriving like they should be. So the first thing we think about is bringing in a little bit of in-home care. And most of the time we think of that being agency help, where you're going to call a home care company, and there are a whole lot of them out there today. They're, well over 100 just in this general region. And they're going to be able to come into your home and offer kind of a care plan that's just what your loved one needs. Sometimes convincing them is the hardest part. So for us, living with my mom in our home, we brought in, fortunately my mom was just very amenable to whatever worked best for me. She was a caregiver for her mother, so she knew that it was a hard task. So, and I was raising children at the time. That happens a lot. We call that the sandwich generation. The kids, the adult children that are still raising children in their home, but also realizing that their parents need some additional care. So when we look at the non-medical, that is typically not paid by insurance. That's typically private pay, unless maybe you have a long-term care plan. And we'll talk a little bit more about ways to pay for things at the end. So we talk about, first of all, would just be companion services. Like if you feel like they're lonely, and that was another topic I heard. If you feel like they're lonely and you feel like maybe they're isolated and they could use a little more companionship, we learned during COVID that isolation really does damage to our psyche and how we function. So a companion would just be somebody that's going to come in really for support and socialization. So I say this might be somebody, think of somebody just coming in to have tea with them, maybe just to sit next to them and watch their favorite shows. They might do puzzles, play games, play cards, whatever it is your loved one likes to do. That's kind of their role, is just the socialization piece. The personal care aide, I think, probably is what we think of when there start to be kind of more challenges with them actually physically taking care of themselves. So this will be the person who's going to help with what we call the ADLs, activities of daily living. So they're bathing, they're dressing, their hygiene, just all the things that help them physically do the things they need to care for themselves. And then the third person would be a homemaker, and they would be coming in to help with all the activities that somebody would normally do to keep up a home. So the cooking, the cleaning, the laundry, they might go run some errands, go to the grocery store for them, to even take them to the grocery store. They might do some meal prep, anything like that that keeps the home running. And then I would say the personal care aide, the person in the middle, can kind of overlap all these different services. So they can, come in and they'll set up a schedule, say, for bathing 2 or 3 times a week, and helping them, dress and plan for their personal care and their hygiene. But they can do any of these other things as well. Obviously they're going to be spending time with them, so they can work on socialization. They might even do some exercises. Maybe somebody's been in the hospital and had a rehab stay, or has had some home health in their home, and they have maybe some physical therapy exercises to do. They can help make sure that they're doing all of those different things. Then the next thing we'll talk about, and one thing that I'll mention here, the non-medical, we see that running about $30 to $35 an hour in today's market. It's not inexpensive. But the other option to hiring an agency is that you could, potentially hire somebody that is in the community. Maybe somebody has been a caregiver, and I think, maybe sometime, after we close up this business, maybe I would go back to caregiving a little bit because I enjoyed it. A friend of a friend, that kind of thing. So hiring somebody personally that doesn't necessarily work for an agency. We did a little bit of both. We had some personal duty that were just private, and then some that actually worked for agency, and there are pros and cons for both. So we'll talk about that a little bit too. Okay, so then we're going to just talk about the types of in-home care, and this is going to be medical. So when we talk about this, we're talking about you've probably had a referral from your physician. Maybe you've had a fall and not necessarily gone, and had a rehab stay, but you're going to do your therapy at home. And so you could have a speech therapist, a physical therapist, an occupational therapist, or you could have a combination of any of those. And that team of folks is going to be overseen by a nurse. They'll come in and learn what the doctor's orders are for your loved one, and they'll set up a care plan, and they'll kind of be the coach of the therapist to let them know what's expected, what the doctor's ordered for you. And they will also have a home health aide, so much like the personal aide that we talked about that you're hiring that's non-medical. This person is going to do many of the same things. The difference between medical and non-medical, this is typically going to be paid by your insurance. Your physician's ordered it, and the personal aide that comes here is going to have a much more limited scope of time. They might be able to come in maybe 3 days a week and spend an hour at a time, versus the home aide that's non-medical that you hire privately. You're going to come to a decision about how many hours are appropriate for the things that your loved one needs. So you're going to be kind of making that decision. So these folks are not the folks that are going to come in and take care of somebody while you go off to work for the day. That's going to be more the private pay, non-medical model. And I think we covered that pretty well. The other thing that I'd like to share about bringing folks into your home is hospice. And I don't know if any of you have had an experience with hospice. My thoughts were probably different about it before I had the experience, but I think that hospice is a very underutilized, very misunderstood program, that hospice is typically paid for by Medicare, so folks that have worked have paid into it, their whole lives, and it we had hospice care for my mother. I think a lot of times we think, wow, that means that my loved one's not going to live much longer. My mother lived on hospice care for 3 years straight. And she's maybe a little bit of the exception, but she had a Parkinson's diagnosis, as Maureen mentioned, and she qualified for hospice probably about 2.5, 3 years into her disease process. And it was just truly a godsend to have these folks in our home. There were some really special people, and spending 3 years with them, I'm still friends with the hospice chaplain today. So we kind of keep up with each other. But you're going to have, again, a nurse that kind of oversees the hospice care team. And you will have a nurse, you'll have a social worker, you will have grief support. So as you're going through this experience, if you need some counseling, they can come to your home and provide that for you. They'll do pain management. And they're not only going to provide services to the person who is on their caseload, but to the entire family. And I say my mom was on hospice for 3 years because she was on hospice. And her quality of life was better, and our quality of life was better. And it's hard to have people come into your home. Yes, ma'am.
I took care of my husband at home for a year. He had lung cancer, and I tried to get hospice to come in. I tried every way I could. They never helped me, not 1 hour, not 1 day, not at all.
That's interesting.
I could never figure it out why they would not help me. And the only thing they said finally was because he had chemotherapy. So then he was still having therapy to live.
Yeah, and that is the difference. So the question was,
Because I thought he was going to live doesn't mean he was going to live, and he didn't live.
right. Well, and that is the difference. You bring up a really important point. There is, when you come onto hospice care, you are making some decisions about what you're going to do medically for the future. So Mark's mother is on hospice care now. She's in a memory care facility locally. And so we've decided she is no longer seeking treatment. So she's no longer going to the hospital. So it sounds like the reason your husband didn't qualify for hospice is that he had cancer. She mentioned that he had cancer, and they didn't bring him onto hospice service because he was still seeking chemotherapy. If you had made the decision to give up the chemo treatment, then most likely he would have qualified. So that
I finally did, but by that time it was, I didn't need he was in hospice for 5 days before he passed away.
yeah, that's
Really close to the end, so they weren't clear. I live in Warren County. It may be different in another county.
well, we were in Warren County as well. That is just, and we can talk more about that if you want to afterward.
They just need to make it clearer.
Yes, and I agree. And there is a part of hospice, since you bring that up, there is a part of hospice called palliative care. And that's kind of a step down from the actual hospice program. So you can be on palliative care if you are continuing to seek treatment. So that is going to be for more of a chronic situation. And the great thing, we tell folks all the time, get a hospice evaluation and talk to them about whether or not your loved one qualifies. Because if they don't, that's okay. If they have an assessment and they don't qualify, that's okay. That just means they don't qualify today. But maybe a month from now they will. And if you're working with a hospice group that has the palliative branch, they can get you started on palliative care, and you still have a nurse. They aren't going to provide as many resources, but you'll still have a nurse that's able to come in and check on your loved one, or that you're able to reach out to if you notice significant changes and want them to come out and reassess. So it's kind of a back and forth, and you can start on palliative care maybe in a situation like someone having cancer that wants to continue with treatment. And then if you make that decision that I think maybe we're ready to step up to hospice care, you can go up to hospice care. With my mom, she did so well having them come into our home that we thought multiple times that she was going to graduate from hospice. And we talked about her stepping down to palliative care and the palliative care team. For us, that never happened. She would have another fall or another urinary tract infection or something that caused her to stay on services, because they do reassess. I believe it's every 90 days once they're on services. But the other thing I want to mention is not just the personnel and the team that's going to be caring for your loved one and your family. And I'll say it can be in your home, but it also can be in a senior living community. It's anywhere that somebody that needs the service lives. So it's in your home, wherever that is. And is that they can provide medical equipment. My mom started out with a hospital bed. At some point, she needed an air mattress, so they brought that in. They can bring in shower chairs and just any multitude of what we call durable medical equipment, and that will be covered under the hospice benefit, so covered by Medicare. They can also, a lot of people I think have the misconception that you're giving up all medication, and that is not the case. They will typically look at medications and say, we don't believe this is really a benefit to your loved one anymore. For instance, Mark's mom was on a cholesterol medication. They said that's not really a benefit to her anymore. She needs to stay on her high blood pressure medication, but the cholesterol medicine isn't really helping anymore. So sometimes just those things that they don't see a benefit in. But the other things, my mom's Parkinson's medication was paid for under the hospice benefit. So it can really be a cost savings to a family if your loved one fits in hospice. They can provide incontinence supplies, all kinds of hygiene products, any type of equipment, again, that's required, even just the incontinence products and wipes and all of those things that they provide can really save a family a lot of money. If you've dealt with that at all or looked at the cost of that, you can see the benefit in that. And we can, certainly answer more questions. Then we're going to talk about how do you choose a provider, because like we said, there's so many to choose from. So that's one thing. Mark and I, through Senior Care Authority, have a lot of vetted resources, and we love to help families kind of put together the pieces of the puzzle, whether you're keeping your loved one at home or you're ready to make a transition. So one thing I think we all think about a lot is references. So maybe you've had a friend or a neighbor or a family member who's had a good experience with an agency and felt like they had good quality care. So references from somebody that you know and trust. Then we want to talk about, does the provider have the necessary license, which that's a benefit of using an agency. They're going to be licensed and they're going to carry insurances. Are they bonded? Being bonded means that they're going to take care of any unfortunate things that might happen, because all of these people we're bringing into our home are humans, and they may take something or break something accidentally, or there might be an accident. So you want to know that if you're working with an agency, that they have the insurance to cover them and that they would cover them. And as far as, do they provide insurance for their workers? If, let's say they're coming to your home and it's an icy day and they slip and fall and injure themselves, are they going to cover them medically, the needs of their worker medically? Otherwise, if you're working with a private duty aide that you've hired privately, that's probably going to go on your homeowner's insurance. So you just want to be sure, eyes wide open, asking those questions when you're hiring somebody to bring into your home. And then if you're dealing with a loved one with dementia, which we're now experiencing dementia with Mark's mother, who had a stroke and has vascular dementia. My father also had frontal lobe dementia. So we learned that if you're working with somebody that has dementia, somebody having specific training can help that whole process be much more enjoyable and relaxed for both the caregiver and the person they're caring for, because somebody with dementia might say something inappropriate or have an inappropriate behavior, and if the caregiver's blindsided by that, it can just turn into this spiral that just doesn't go very well either for the caregiver or the person they're caring for, and you can end up with a very agitated situation when it didn't need to happen if somebody had the right training. And then things to discuss if you're bringing somebody into your home to care for your loved one: their personality. My mom was really quiet, and we brought in a caregiver one day, and we were probably a couple years into the caregiver journey. She was with us for 6 years. And this new caregiver came, and she was lovely. I talked to her before I left. And at the end of the day, I said to my mom, Mom, how was your experience with this new gal? And she said, she talked all day long, and I am exhausted. Because I didn't think to tell her. My mom really just, she'll enjoy your company if you just sit with her. She likes a little bit of talk, but not a whole lot. She would be happy sitting in her room watching Hallmark videos all day. So tell about personal habits. Again, that kind of comes back to, are there things they might do that somebody might think is inappropriate, or also their levels of cognition. How well are they going to communicate? How well are they going to understand what you're communicating to them? Daily routines, which are important to most of us. We're creatures of habit, and so if we can keep things on a regular schedule, whether the person has dementia or not, they're probably going to be more comfortable following their normal routine. Do they like to get up early and eat breakfast right away? Do they like to have a slow morning start? What does that look like? And then I talked a little bit about their communication skills. How do they understand? Are there certain phrases, especially if somebody has dementia or is nonverbal maybe? How do you communicate well with them? What is their mobility like? Do they use some kind of assistive device? Do they have a rollator or a walker or a cane? Mark and I see it all the time in memory care. They can't remember that they need to use a walker, so somebody's always having to remind them. So you can't count on the person that needs the help to say, I need to use my walker. So as a caregiver, you need to share that. And then these things are just about helping them know who the person is, because you want them to make a connection with your person, not just the treatment of them. You want them to really get to know who your person is. And so talk about the family, talk about things they like to do, hobbies. I say likes and dislikes. I say the dislikes are probably maybe more important than the likes, because especially if somebody has dementia and you give them something they don't like, again, that can cause agitation that wasn't necessary. Talk about their previous occupation. Again, you're trying to help them connect with your loved one. And then talk about those common dementia-related behaviors. My dad, and I don't know what he would think of me using this story, but my dad was a deacon of the church, and I just knew him as, this upstanding man, and he gets dementia, and I go into the skilled nursing facility where he was, and he is just using words I didn't even know he knew. And fortunately, there was a very kind nurse that kind of pulled me aside, because I was so embarrassed. I was embarrassed for myself. I was embarrassed for him, and embarrassed for the people that were experiencing this. And she said, Rachel, this is not your father. This is the disease. So sometimes we have to remind ourselves to kind of disconnect from that and realize our person isn't choosing those behaviors. It's just part of their disease process. And then I say at the end, just tell somebody, if you're having somebody come in to care for them, and again, this depends on what their cognition is. Maybe they have more physical needs than cognitive needs. But just tell them what they need to know. If they have dementia, they're probably not going to remember much of what you tell them. But if you can be there the first day and spend most of the time together and then maybe just quietly slip out. And I don't want to compare older adults to toddlers, but in some ways the way we care is the same. You know, getting them comfortable with somebody and then just kind of bowing out and letting that person develop a relationship. And then plan for resistance, because nobody really wants to have somebody have to come in and take care of them, because all of us think that we can just, you know, age in place and take care of ourselves, and hopefully that's the case. With the experience that Mark and I have, often that's not the case. You know, either folks are requiring care or they need to make a move where there's more care involved. So plan for the resistance and know that that's very normal. And then I'm going to turn it over to Mark to talk about senior community options in case you need to make a transition.
All right, thank you. Can you hear me? They tell me they can hear me whisper in the next room, so it's never been a problem of talking loud enough. By a show of hands, who wants to age in place? Absolutely, we all do. We all want to age in place. We work with families that say, you know, I've lived here for 40 years and I plan on dying here. And but sometimes, you know, that's just no longer possible. And we were talking earlier that the only one that likes change is a baby in a wet diaper. That's the only one that likes change. But sometimes change is inevitable. So what I'd like to do is just talk about the senior community options that are out there briefly, but kind of give you an idea of what is available out there. And the first one on the top of the list is independent living. This usually consists of a small living unit, could be an apartment, could be a small cottage, could be a freestanding house on a community. Services typically provided are meals, transportation, housekeeping. They also usually typically provide social activities. You know, the benefits of this is as an older individual, as a senior, you still have some independence. You still have some ability to go about doing the things that you enjoy doing, but then you have the amenities that go along with a community, activities, socialization, transportation, those type things. The negatives is there's usually limited assistance. And what I mean by this is Rachel mentioned activities of daily living. Those are transfers, bed mobility, toilet transferring, ambulation, eating, dressing, showering, those type things. Those are activities of daily living. If you're in independent living, those are sometimes very difficult to attain, and you might have to pay independently for that. So you may find that independent living doesn't provide you the needs that you want. The next one down on the list is assisted living. These communities generally provide 24/7 care. Could be aides, could be nurses, but they do provide 24/7 care. Again, they provide recreational activities, meals, housekeeping, laundry, transportation, and typically you get to choose the services that you want or need. So you may need medication management. My mother was in skilled nursing and then transitioned into assisted living, and she needed all the help, but courtesy of therapy and time in the good Lord, she only needed medication management. So she was able to eliminate some of those services that she needed and only needed the help with the medication. So living options include a studio, 1 bedroom, and some communities also have 2 bedroom options. The benefits again, is you have that assistance. You have people available to help you do the things you need to do. For instance, my mother initially needed help getting out of bed, needed help dressing, needed help getting to the dining room, and those type things. But again, she graduated from most of those. The negatives is it can be expensive. Assisted living can be expensive, and a lot of it depends on the needs that you need. There's typically a base pay for the kind of renting the space, and then depending on how much you need, the price could increase. Some places, some assisted living communities are what they call all-inclusive, meaning the rent and whatever care you need is included in the price. The other downside of assisted living is that you've lived in your house for 35 years, you've done everything on your own, and now you need assistance. And sometimes that's a challenge for the individual to accept that need of assistance. The next one down on the list is personal care. These are also referred to as residential care homes or adult foster care. We've also heard them referred to as elder care homes or adult family care homes. In this area, they're kind of rare, but if you go to California or go to Arizona, they're everywhere. When we first purchased this franchise, they asked us how many personal care, 5 years ago. There were 3 personal care options in this area, where in California, in one territory, there might have been 500 personal care homes. So they're kind of catching on here. And one of the benefits is that there's typically a higher ratio of caregivers to individuals needing need. And one of the reasons for that is in the state of Ohio, you can only have at a maximum 16 people. So in one home or one freestanding building, you can only have 16 individuals at the most. And a lot of them have 5, 6, sometimes as little as 3 in a home. So it's intimate, it's quaint. The one I'm thinking of, they took a home in a neighborhood and they rehabbed it and made bedrooms, converted the garage into a bedroom and those type things. So everybody eats together and they watch TV together, and it's just kind of like being at home. The negative part is, particularly in this area, is there's a limited number of beds. So could be quite a long waiting list, could be a wait to get into these buildings, and the cost is typically higher because of the cost of staffing and the higher staff to resident ratio. The next one is skilled care. Now, everybody in this room probably thinks, oh, nursing home. And if you're my age or older or about my age, you know, the connotation that I think of with a nursing home is where my grandfather went to die. But that's not skilled nursing anymore. Skilled nursing kind of has 2 tracks. There's one track where, yes, indeed, it's the individual that needs care 24/7 to meet their needs, and that's probably going to be their home until the good Lord calls them home. That's one track. The other track is where I worked and where I kind of lived, is skilled nursing. So the individual goes to the hospital, has a 3 midnight stay in the hospital. They then qualify through Medicare to be paid for skilled nursing, and it was my responsibility to get you home as quickly as possible. So I got the pleasure of working with you, kicking your fanny, getting you home, because that was the idea. So you spend a couple days in the hospital, you come to skilled care. I work with you for a week to 2 to 3 to 4 weeks, and we get you home as safely and as quickly as possible. So really with skilled care, there's two avenues. So the benefits of skilled care is they provide those specialized care, whether it be the therapies that Rachel mentioned, physical, occupational, speech, sometimes respiratory therapy, wound care. If you have a wound that's greater than what we call stage 2, and a stage 2 is kind of an abrasion. So if you have anything that is a deeper wound, you are in skilled care to get wound care. And then medication management. The negatives about skilled care is it seems real clinical. It isn't. Most of your assisted living, independent living, personal care are very homey, very bright, very welcoming. We'll bring adult children in and they'll go, oh, this is nice, I'd like to stay here. Where in skilled nursing, it's more clinical because that's kind of the environment it is. And you'll have less control over your daily routine. When I was in physical therapy, I'd give you the opportunity to eat breakfast, and then you were doing therapy because you were there for therapy. So if you like to watch if you like to watch Bob Barker, ooh, that dated me, didn't it? If you like to watch Bob, well, too bad, because you had therapy and that's why you were there. So less control and limited privacy, because sometimes the rooms are shared. The next one down on the list is memory units. Memory units offer specialized care and support for those individuals that have memory impairment. Excuse me. It provides a safe environment, a protected environment. The benefits, and Rachel again alluded to this, is most of the staff is trained to handle dementia behavior. So the individual that's been diagnosed with dementia sometimes has unique behaviors. These individuals are trained to handle that. It's a secured unit which will protect the individual both from wandering and will also provide that safe environment. Unfortunately, the negatives about this is that it's restricted. So the individual that's just experiencing memory issues may feel a little compromised because it limits their independence. And quite frequently, these communities that have memory units are full. And it's getting tougher and tougher to find open beds in dedicated communities. The next one is community care retirement. We call these CCRCs. It's kind of our lingo. What they are is a continuum of care. So most people will start in independent living, but on that campus, they have independent living, assisted living, memory care, and skilled nursing. So the individual knows that if they choose to go into a CCRC, that they're covered and they can stay on the campus. So it provides security and peace of mind. You don't have to worry about where you're going to go if your needs increase. Unfortunately, the negatives are typically your CCRCs ask for a hefty fee up front. And then you have ongoing monthly fees and an entrance fee. So it can be kind of restrictive financially for some seniors. And then typically if you need a higher level, you are going to have to move. You'll be on campus, but you'll probably move to a different room or to a different building. So here are some of the things to consider if you're selecting location. Location is huge. You want to be in a location that's close to you. It's interesting. We moved my mother from Houston, Texas to this area, and we moved her into assisted living, now in memory care. And I didn't think of myself as a caregiver because my mom was being cared for. But you're still the caregiver. You're still kind of supervising, you're still kind of overlooking it. So you want a convenient location. You want to find out how they do care planning. They set up a care plan for your loved one, and you want to be involved in that and ask them how you can be involved in that. Will they provide transportation? There is one assisted living that we toured with a family that they'll take their residents up to 20 miles away. So the one person that we were touring always spent Sunday with their adult children. And the community said they'd take them there, pick them up, and bring them back. So those are questions to ask. How will the staff provide care? What's the environment like? We encourage families when they do tours with us to look at the staff. Do the staff engage you? Do they acknowledge you? Do they look you in the eye? Do they look like they're engaging with the residents? Because if they're doing it when you're touring, they're probably doing it when you're not there. And do the residents seem engaged? We've done some tours at 2:30 in the afternoon. Now, I don't know about you all, but my dream is to get up really early, take a nap in the morning, get up, do some work, eat lunch, take a nap in the afternoon. So if you tour some of these buildings in the afternoon and everybody's in their room napping or they're in the TV room napping, don't be surprised, because that's my dream, is the nap in the afternoon. So we encourage people, if you can, just get close, tour during meals or tour during a more active time. And then is the unit secure? Some information that I would suggest each and every one of you in this room have for yourself and have for your older loved ones. Name, date, possible social security number. Have that available, because in an emergency, you're not thinking. Have those things available. Physician's name and phone number, current information, any diagnosis, health or behavioral care needs. Rachel mentioned, about the individual that's been diagnosed with dementia. They're going to have different behavioral care needs. List of medication, allergies, do not resuscitate. If you don't have from Rachel's mother, who lived in our home for 6 years, we had on the refrigerator the do not resuscitate orders. If the EMTs came through our front door and we didn't hand them that piece of paper, they would have started CPR on Rachel's mom. And that wasn't Rachel's mom's choice. So special care needs, any of the equipment that they need, and those type things. So those are the things, and I'm going to pass it back over to Rachel.
Okay, so the last thing that we're going to talk about, and then we'll open it up for questions, is just ways to pay for the care that we're talking about, whether that's bringing care into your home or having care in a community. So obviously private pay, so that's going to be, your savings. Maybe you've sold a home and you have those assets to pay for care. Medicare, I think people have the misconception a lot of times that Medicare is going to pay for long-term care, and they do not. They do pay for, like Mark mentioned, as a physical therapist, he was providing rehab care and therapy. So they will provide for those rehab services that are necessary to get someone from the hospital to rehab back home safely, if that is something that can happen. And there's a certain period that Medicare will cover, up to 100 days under certain conditions. And so that's just misunderstood. A lot of people say, and they'll call us all the time and say, well, my dad has Aetna insurance and they have Medicare. And it's like, well, that's great, but that's not going to cover the care that you need. Another way to pay is Medicaid. And in the state of Ohio, we are very fortunate in that we not only have Medicaid for people that need it, that are living, in the community and have Medicaid as their health care coverage, but also for skilled nursing and also for assisted living. Most states cover skilled nursing, but most states do not cover assisted living. And assisted living, again, as Mark talked about, is the more homey, more comfortable environment to be in. It's also much less expensive. So I would think as time goes on that other states would jump on the bandwagon of paying for assisted living under Medicaid, but we're very fortunate in the state of Ohio that they do. So when we're working with a family, one of the discussions that we have is finances. It's just like, sometimes I compare us to a real estate agent, just the outcome is different. If we're talking about transitioning or making a move, we're talking about senior living versus looking for a private home. But a lot of the discussion is the same, because the last thing we want to do is help you move your loved one into a community and then realize you didn't have enough money to pay for it long term. So if the need is there, we're going to share with you the communities that will accept Medicaid after a period of time. Some of them will accept Medicaid, we say going in the door. So they will accept somebody that is Medicaid pending. They filled out the application and they're waiting for approval but expect to be approved. And they'll even help you through that process. Other communities, which is more common, but still not as common as we think it'll have to be in the future, is that communities will take a period of private pay anywhere from like 18 months to 2 years, and then they will accept Medicaid. So they want to make sure that you have the finances coming in the door to cover that first period of time, and then they'll accept Medicaid. Again, you have to qualify for it, so you just can't have millions sitting in the bank and somebody else pick up the ticket. However, there is estate planning, and each family has to make those personal decisions about that, and that would be, and we highly refer to elder law attorneys that specialize in Medicaid planning, so that there are some assets that can be preserved. And I say the thing that I look at, like if somebody's had a family farm that's been in their family for 100 years, and that's really an asset that's important to keep, then talk with an attorney about ways that can happen. And it's better to plan early, especially if you're looking at asset protection. So Medicaid, again, is a program that really we've all paid into to support those that need assistance. Because one day it might be us. Nobody really plans for that or thinks that's going to be them, but it happens a lot of times. Both of my grandparents in their final days had to have that assistance. So there's no shame in it. It's a program that's available. A long-term care policy. A lot of the older folks that we work with have these wonderful long-term care policies that they bought many years ago, that we had worked with one gentleman that had an unlimited policy that he could, spend basically any amount of money for any period of time. They don't write those anymore. And if you can get long-term care policies, often most people advise that you start looking at that in your 50s or early 60s, because if you wait too long or you have some type of medical issue, you're not going to qualify, or it's going to be, cost prohibitive. Another tool is called the HECM, or Home Equity Conversion Mortgage, otherwise known as the reverse mortgage. And that might make some of you cringe even to hear that. The reverse mortgage, unfortunately, there were some, kind of consumer, some things that weren't benefiting the consumer of companies that were doing those original reverse mortgages. So the government got involved. So what could be better than that? But they actually did put in some consumer protections and make sure that folks are required to get education so that they understand what they're getting into when they do one of these home equity conversion mortgages. And it's definitely not a program for everyone, but in the right situation, it can be really, really helpful. Again, it's just a tool. VA aid and attendance, that's a program that our veterans qualify under certain certain restrictive date periods. So there's a whole list of when they qualify, but this can be up to, I think the current veteran themselves, I think the current monthly income is about $2,300 to $2,400 a month in assistance. So there is some asset qualification, but the biggest thing is their service qualification. So the county veterans offices can help you figure out those applications, but a lot of people miss that benefit so it's something that you want to think about if your loved one was a veteran. And then also life insurance policies. Sometimes we see that a couple that had life insurance policies, maybe one spouse has passed away and that coverage is really no longer needed. There's not somebody in the family that really needs that benefit. So you can actually sell an insurance policy and recoup some cash for that. So we can just kind of help you look at those different options and get you over to experts in those fields that handle all of these different products. And that's really our goal, is to connect families to the right resources. We have a lot of experience. We have dealt with a lot of things personally, but we always say staying in our lane and we're always going to refer you to the professionals that can handle your specific needs and get you to the right resources. So that's all we have for now. So if anybody has some questions, we're happy to take time to answer questions. And we do have some brochures, and our business cards are out on the table. So if you have a question that you don't really want to talk about publicly, you can always give us a call. Our cell phones are on our cards. Don't hesitate. You can call our cell phones and our emails as well.
Thank Springboro.
Yes, absolutely. Thank you so much to the City of Springboro and Premier Health for asking us to come out. And so if anybody has any questions, we're happy to answer those. Yes.
Could you perhaps talk a little bit about what the state of Ohio rules or laws are for senior driving?
That's a Mark question.
That's a Mark question.
Nope, sorry. We'll just stand close together.
What are options? Well, in the state of Ohio, you really kind of, one of our services that we have is a service called Beyond Driving with Dignity, where I'll go to the senior's home, we'll have a learning conversation, we'll run through some cognitive exercises, and if I feel they're safe, they have a valid driver's license and insurance on the car that they want to drive, we'll go for a drive. The key to the program, and when I do public presentations on how to extend your safe driving years, one of the first questions I ask is, who wants to give up their driving? No hands go up. And I ask them why. And almost everybody in unison says isolation. So the last part of the self-assessment is bringing the family in and helping keep that individual independent. Now, that's one option. Some of the community hospitals in our area also provide a clinical aspect of that through occupational therapists. I'm a physical therapist, and it's mostly done through occupational therapists. The process for that, if you go to a clinical thing, you need a doctor's prescription. They then do the assessment. They make their recommendations, send it to the doctor. If they recommend that the individual stop driving, the doctor then has to fill out a 2-page thing that goes to the Bureau of Motor Vehicles. The Bureau of Motor Vehicles then sends the older driver a letter, says that you have 30 days to show up to be retested. If you don't show up within 30 days, your driver's license is invalid.
This is all instigated through the doctor.
Yeah, but the challenge with it is, does anybody know that's driven on an invalid driver's license? So the hardest part is in educating the older driver that it's now time to quit driving. The National Highway Traffic Safety Association says if we're all blessed to live long enough, we'll outlive our safe driving years by 8 to 10. So the key, and one of the benefits with moving into assisted living or memory care, assisted living or independent living, is most of them provide transportation. So you can go in, my kids could come in and say, Dad, you have to stop driving. And I would kick them in the shins and I'd send them out of my house. But if they came in and said, Dad, the neighbors told us you ran over the mailbox again, or you've backed into their car again, Dad, you really need to retire. And this is our plan to help you get to church. This is our plan to help you get to McDonald's for your visit with the boys. When you go in with a plan, with objective findings and a plan, then the older driver usually takes that a little bit easier, but you got to have the plan. Great question. So the question was, what does the state of Ohio do in regards to older drivers? Terry?
Well, first, you're to be commended for putting church first. I'm a veteran, and I think in the old days, years ago, a veteran could go to any VA facility and get almost any kind of care free. You're saying that that's different now, is that correct? Qualification?
It's a different.
No, the benefit we were talking about is assisted living. It's a VA assisted living benefit waiver. Oh,
Nope.
You're going to get clarification.
Yeah, that's on my slide. Actually, the VA aid and attendance is just a different benefit, Terry. So you could qualify for those services, at the VA hospitals. And we encourage veterans to take advantage of all those benefits that they get. The VA aid and attendance is actually a different program that provides for care once you need care. So I'm going to change what Mark said just a little bit. It could even be to pay for care in your home, to bring care into your home, which that's one thing I didn't think to mention. There's also a program specifically for care that some agencies, if you see on an agency that says we're VA approved, that means that they can accept payment directly from the VA. So there are a few different types of benefits, but the VA aid and attendance is just one that I feel like a lot of people just don't ever even hear about unless they hear somebody talk about it specifically. So can be a big benefit, especially if you're looking at needing to bring care into your home or moving to a facility. Again, you need care, so they wouldn't pay for independent living, but at the time you need some kind of assistance. Yep. Anybody else? Yes.
On the do not resuscitate thing, and I know you said you had some experience with that with your parents, and I did with my mother as well. We thought we had that box checked. We thought we had done everything with her living will, all of those things. But when push came to shove and she had a fall and she had to be transferred from a smaller campus to a main campus of the hospital, we thought we had that figured out. Didn't realize I had to have a signed order from the doctor. Thought her living will papers were enough. It was not. Found out that the doctor, in the hustle and muscle of trying to get her transferred, the doctor forgot to sign. So my mother went in the ambulance from one campus to another without a signed do not resuscitate form, which I'm like, do we have it? Do we have it? Yes, we have it. She was 96, very frail. We didn't, and it was just an oversight. Something didn't get signed. Out the door she went. Luckily, they didn't have to do that. But I was unaware of that.
Well,
Living will was all I needed.
And the question was, essentially, I'm going to summarize this. The question is, what role does the do not resuscitate play, and where do you have to have it available? And that's kind of that one slide with the papers, where you just need to have a packet. Do not resuscitate in the state of Ohio, and correct me if I'm wrong, needs to be signed by a physician. You just cannot do a do not resuscitate where the EMTs are going to say, scribbled out, do not resuscitate and signed. It needs to be actually.
Leave that paper with you every time you have an EMT.
Absolutely.
That's right, okay.
Absolutely.
Packet or copies of that.
I would have a packet, that if the EMTs walked into the door of our home to take my mother-in-law, just hand them the whole packet, got all their medications, all their physicians, all their diagnoses, and all their important power. And I will put a plug in, again, we're not attorneys, but I will put a plug in for those in the audience and those that are caring for loved ones. Please have power of attorney, financial and medical, and have a second. So Rachel and I have power of attorney for each other, but we have a second if something should happen to us simultaneously. So we have children that will step in as seconds. If you don't, a little story about power of attorney. We had a gentleman, and the owner of the franchise told us this story. He had a gentleman whose wife was diagnosed with dementia. He did not have power of attorney, but he needed to sell the house to afford care for his wife. Both their names were on the deed. So because she had dementia, because she was diagnosed with the dementia, she could not sign off to sell the house. He needed to get guardianship, which took a year and cost him $19,000. So for a couple $100, you can contact an attorney, get all your paperwork taken care of, your power of attorney taken care of. For anybody in the room, you need those power of attorneys, so that could be one of those pieces of paper in that packet that you send with your loved one to the hospital. Any other questions? Thank you so very much for joining us.